starting now. And so I want to welcome you to this presentation. We're really impressed with the variety of people attending and the turnout. It's been great. If you have any difficulty, I will try to fix that for you between Mark Hager and I think we'll be able to make that work. We'll be using question and answer. Dr. Zeller will do his presentation and then we'll take questions later. So Shane Trombley will be monitoring the question and answer. And between he and I, we'll be able to gather those and we'll address those toward the end of the presentation. We first learned about EmPATH a couple of years ago and visited a Fairview Southdale unit, and we're quite impressed with that. And so, NAMI is interested now in seeing if there's a way for us to learn more about that as a community and gather support for this idea. I saw Dr. Scott Zeller speak at the National NAMI Convention in May in Minneapolis, and you did a great job, Dr. Zeller. I was very pleased with your presentation and have been thinking since May about a way to get you here. So I'm very glad that you could join us today. I will introduce his, maybe 1/10 of his qualifications to be here. But I do want you to know, besides what was in the flyer, that in addition to being vice president for acute psychiatry at Vituity, which is a physician-owned and led healthcare system, he is also assistant professor at University of California, Riverside, and he is an international speaker. He has published research, textbooks, many articles. He's the 2015 Doctor of the Year for Behavioral Health, the 2019 California Hospital Association, I think it's Heerman Award, and that was for his landmark contribution to healthcare. And lest you think he is purely an academic, he has 30 years of actual psychiatric practice, and he has cared for 80,000 patients. And so we are very honored to host Dr. Zeller on EmPATH, a concept that he actually pioneered. And so, Dr. Zeller, he has a PowerPoint presentation, and I will turn it over to you.
Well, thank you. It's so great to be here, and I really appreciate that. It's very humbling opening introduction. So thank you. We were very kind. Hopefully everybody can see the screen. We're seeing something where you see some table and chairs and desks, and it says EmPATH units improving hospital care. If everybody's good with that, we can go ahead. I think I have control of the slides. And if that's the case, hopefully we'll be somewhat streamlined. So let's just start from there. And as we said, we're talking about EmPATH units today. And EmPATH units are really a different way to deal with what are known as psychiatric emergencies. And so for a real quick definition before we go any farther, psychiatric emergencies are when somebody, due to a behavioral health condition, is considered dangerous to themselves or dangerous to others, or can't take care of themselves, or they're really close to evolving into those conditions. And there's a few things that you need to think of differently. So, for example, I have a friend who jumps out of airplanes on surfboards and surfs the air before popping his parachute. I think that person is a danger to himself. However, by legal criteria, that's not somebody you would say is danger to himself for psychiatric reason. Maybe I think he's a little, not thinking too clearly, deciding to do that. But we're thinking more about acute conditions caused by diagnosed behavioral health conditions. Somebody like a mafia hitman might be a danger to others, but they're probably not going to meet the criteria to come into the psychiatric hospital because their behavior is due to something outside of a psychiatric condition. So that's a really important concept. And when people, you might hear sometimes say, oh, why isn't this person doing that? Or why isn't that person doing that? We try to really restrict behavioral emergency care, crisis care, psychiatric emergency care to people who want to engage. And if they can't engage, they need to really have specific issues that they are involuntarily detained for, or they're at that same level that hopefully they'll voluntarily engage with us. So hopefully that wasn't too complex. But even with that kind of narrow definition, we're now seeing in emergency departments across the USA between 12 and 15% of all the patients coming to ERs in the USA are there for a behavioral emergency. That's a huge number. It's probably more than people who are coming in with broken bones or chest pain or a whole bunch of other things you'd imagine that ERs would be seeing. Right now, it's 1 in every 7 patients coming into the ER across the USA, across Canada, is coming there because of a psychiatric behavioral health emergency. And this is leading to millions and millions of folks seen in hospital ERs. And what we've seen as we've evolved out of COVID is that the numbers have just continued to grow, and they've grown really, really precipitously. A key thing to remember is that we're in the USA, and so we're talking about USA laws here. Under USA law, the law known as EMTALA, the Emergency Medical Transfer and Active Labor Act, has been in effect for well over 30 years. Psychiatric emergencies are considered the same thing legally as medical emergencies. So if you're somebody who has a psychiatric condition that's making you dangerous to yourself, danger to others, or unable to take care of yourself, that's considered to be an emergency the same way that somebody having a heart attack or being in a car accident, chest pain, shortness of breath, any of the other things we would consider true medical emergencies coming to hospital ERs, psychiatric emergencies qualify those as well. So when we start thinking of it that way, it's maybe a good time to recalibrate the way of thinking. Unfortunately, I've met too many people who work in emergency medicine who say, like, well, these people should be going somewhere else because this is a place for people with medical emergencies. Well, you know what? These are medical emergencies, and federal law says so. So instead of thinking and closing your fingers and saying, crossing your fingers and saying, oh, I just wish we could find another place for these folks to go, you would never do that for people coming in with chest pain. You wouldn't do that for people coming in with shortness of breath. And instead, maybe you should say, you know what? These patients are our patients too. They're not going to go away. Let's start doing a better job embracing them coming in, doing what we can to help them out. And hopefully they're going to get better, just like the vast majority of the patients we see with other conditions in the ER. So along those same lines, with people saying, boy, wouldn't it be great if people with having these psychiatric crises, these psychiatric emergencies, if a community, a region could find somewhere else for them to go besides the medical ER. And it makes a lot of sense. It seems like a great idea. And so a lot of the last decade or more has been really focused on creating programs in what we'd call the community. And when we say community, we mean outside of hospital grounds, outside of hospital property, hospital influence, where maybe you would set up a crisis center in what formerly might have been an office park or a standalone center or near the community mental health clinics or something like that. And these are for drop-in, immediate crisis intervention, sometimes crisis stabilization, involvement, helping people who are having a horrible, horrible behavioral health condition, a behavioral health crisis. Wonderful, wonderful idea, wonderful programs. Can't say enough good things about them. However, there's a little bit of a dichotomy going on in that sometimes people said, okay, we're going to open up this community drop-in counseling center. Therefore, people with behavioral health emergencies aren't going to need to go to the ER anymore. But we look around the country at all the places that these programs were created, and unfortunately, sometimes they kind of promised the local regional government agency that, oh, if you fund our program and help us to build it, the number of patients coming to your ERs are going to go way down. Unfortunately, as much as that sounds like it makes sense, it really hasn't happened that way. We, as I said, are now seeing a continuous rise in people coming to medical hospital, general hospital ERs for psychiatric emergencies, behavioral health emergencies. They're now 1 in every 7 patients that are coming to hospital ERs. And so hospitals that are kind of on the cutting edge and looking a little forward have stopped saying, you know what? we don't hope these patients go somewhere else. We hope as many go to that other place as possible, but we realize there's different levels of severity. And that community health program is great for people who need counseling, who need interventions, who need respite, who need referrals. But we're seeing the kind of people who are coming in who are very, very acute, who are hallucinating, who are threatening, they're combative, they're violent. Those people are just too acute, those community programs. And we need to understand that there's different levels of care. You wouldn't say that somebody come in for an annual checkup is the same as somebody having a heart attack. Of course not. It's the same thing with mental health crises. There's some people who need some prompt counseling, some help, some supportive psychotherapy. And then there's other people who are coming in who are hallucinating, hearing voices, telling them to hurt other people. That's a big difference. We need to have something for both of those types of patients. And that's kind of the idea behind what we're talking about today. We want these wonderful community-based programs to help people in what might be called the mild to moderate levels of acuity, but we're still going to need hospitals, hospital emergency departments when people get to severe acuity. And that's going on right what we're talking now. Here's why you can say, even if you've got the greatest community crisis program in the world, here's why people are still going to come to your medical hospital's ER. For one, the crisis programs are really set up for what we might call mild to moderate severity patients. They're usually ambulatory, they're usually high functioning, intelligent. They've got a family or life crisis. Let's say they lost their job, their spouse left them, something like that. They're really at wit's end. They're thinking unfortunate things and they really need an intervention. That's a great thing for a community crisis program. But these same programs will have algorithms where if somebody comes in and they're on an involuntary psychiatric hold, or they've been violent, or they had a gun taken out of their hands that they were trying to use to kill themselves, or they pulled them out of a noose or something like that. These people are what would be called too acute for those community programs, and they end up going to the emergency department. You can add onto that list that I just described people who are so suicidal you can't be more than 3 feet away from them, or they're going to do something to hurt themselves. If they're in active substance intoxication or substance withdrawal, if they're on involuntary criteria where they're detained involuntarily, every state's got a different version of that. The state I'm from has the famous 5150, which is a 72-hour involuntary psych hold, but every state that I've encountered has some version of that. But there's other exclusion things that these programs that are not hospitals have. Often, if you've got neurologic spectrum, developmental disability, autism, they'll say those aren't patients we can take. Somebody who's been there too much, somebody who is saying, I'll stay at your place, but I won't take any meds, which means they're not interested in treatment. That's another whole interest. Anybody with criminal charges, on and on and on and on. There's a huge list of folks that you need this higher level of care, that you're working in tandem with, that you're complementary to. We want a wonderful, robust community crisis system for the people who can access that, and we'd like to make that program as receptive and take as many people as possible. But just like you wouldn't open up a community medical urgent care, let's say next door to your pharmacy or your Walgreens or your Rite Aid or your CVS, and they've got a drop-in urgent care open 9 to 5 Monday through Friday. Those places are wonderful if you want to go in and you have the sniffles, or you have a scrape, or you want to ask them about your blood sugar or things like that. Fantastic. And isn't that wonderful? People don't have to go to the ER for that. But you wouldn't want somebody with a gunshot wound coming to the doc in the box at the Walmart. I mean, that's just more is needed than they're able to provide at that level. And indeed, if they came to that level, they would forward them on to the nearest ER trauma center. It's the same thing with psychiatric emergencies. We want people who can get that level of care, that's going to be useful. It's going to be the appropriate level of care to get it there. Nobody in psychiatry is looking for extra business with high acuity patients. I guarantee you that. But if there's a number of patients who are just too acute for that community-based level of care, you need to go up to the hospital level of care. And what unfortunately has happened there for far too long is people come in and they get stuck in the ER, and there's almost as if crisis efforts, crisis stabilization is supposed to end when people get to the hospital door. And I think that's wrong, and I'll explain a bit more why. Another quick real thing here is that when we've been talking about things like equity and access and parity has been at the forefront of what everybody's been talking about in medicine the last few years. Here's an interesting fact that I just learned the other day. Black and Hispanic adults, kind of what we might call early middle age, 18 to 44, were far more likely to go to hospital ERs for mental health issues than any other group. And then if you use Black and Hispanic men of all ages, they were the second in line. What does this say? Is that there's a lot of people who, if they have a mental health emergency, they either think I need to go to the hospital ER, or a family member takes them at a hospital ER. And is that the right place for them to go? Well, we would love it. We need to spread information. We need to do better efforts to market and educate the community that there are drop-in programs. There are community mental health centers. There's crisis receiving centers. There's community behavioral health centers, all these wonderful things. And we would love people to go, if that's the appropriate level of care, to go there. At the same time, as I mentioned, anybody who comes to ERs by federal law, we're required to see them, and that's a good thing. That's regardless of their ability to pay. So if they're coming to us, it means that they trust us. It's not a wrong door. We would prefer that hopefully in the future that with these kind of symptoms that they might be able to access some of these other programs that are out there. But at the same time, we're here for them. We're here for anybody who's having any kind of serious medical condition, whether it be general medical or whether it's psychiatric in origin. And along those lines, ERs always accept all people with no discrimination, been at the forefront of that for a long time. Supporting that is a federal law called EmTALA, which basically says if you come within 250 yards of a hospital and you are asking for medical help, you are legally required to get a full evaluation by a physician or an otherwise licensed practitioner to determine whether or not you have an emergency medical condition, and then they need to try to stabilize that condition. All of these things without regard to your ability to pay. So you could be completely impoverished, not a penny in your pocket. You go to the ER, we're going to do everything we can to help you. And if there's something emergent that's going on, we are going to do everything we can to stabilize that for you. And we're not going to ask if you can pay for it. And the insurance folks aren't even going to come by till much, much later after we've intervened. That's what EmTALA says. And I think ethically, from knowing ER docs my whole life, I think they would do that even if it wasn't the law. And that's a really cool thing. But again, remember that the federal law, EmTALA, also defines psychiatric emergencies as medical emergencies. So chest pain, shortness of breath, being in an accident, trauma are the same thing as coming to a hospital where you've got a psychiatric condition that's making you, as we defined at the beginning there, danger yourself, danger others, incapable of caring for yourself. So ERs are really starting to recognize this and saying, hey, you know what? We're part of the spectrum. We're part of the system. Let's do the best job we can with people coming in with behavioral emergencies. This does cause some problems for them. One of the issues is that the average patient with a behavioral health chief complaint ends up staying 3 times longer in the hospital ERs than any other diagnosis. So if you come in with an asthma attack or a broken leg, chances are you're going to stay, less than a third of the time than the average psychiatric emergency patient does in the ER. This is not a good thing financially or operationally for the hospitals. Every psych patient coming in ends up preventing 2 to 3 people who are sitting in the waiting room waiting for help from being able to come in. And that also ends up with a lot of the psych patients, if they have had a system, which is unfortunately still the most common in the US at this point, if the system is you come into the ER, we'll take a look at you, we'll say, yes, you need an inpatient psychiatric bed. Now sit tight, we'll find you an inpatient bed. Sometimes that search for a bed takes hours, sometimes it even takes days. And that's a situation called boarding, where a patient is just stuck there in the ER, sometimes one-to-one with a sitter in a small room, sometimes strapped to a gurney in a hallway. very little to no treatment. Basically, the only contact is when the meal trays come around. And that actually is not only really unpleasant, as you can imagine, for a patient, but it's costing the hospitals thousands and thousands of dollars. The financial loss that I have here, this slide is from 15 years ago. And I think if we've looked at the inflation and everything lately, I think that's probably well over $4,000 by now. So when we're looking at this, what are our challenges? What could we really try to focus on? We've got capacity concerns, and we know that ever since we've come out of COVID, mental health crises are just unfortunately rising at super high levels. This causes bottlenecks and problems in the ED, which is the emergency department. The emergency department teams often don't have good folks trained in working with mental health, behavioral health patients. They get overcrowded in the emergency departments. That leads to some other concerns. But it all rolls down to this one thing at the bottom here, which is too many people still have this idea that if you come to the medical ER at a hospital and you've got serious psychiatric symptoms, the only possible disposition, the only possible destination we can have for you is to move you to an inpatient psychiatric bed. Maybe you have inpatient psychiatric beds on your hospital campus. Maybe you have to send them to a private psychiatric hospital somewhere else, but that's always the treatment. The idea is not to intervene the same way you would with any other patient, but actually say, okay, you need a hospital. Let's spend some time finding the hospital to send to you. And in the meantime, you're just sitting there. You're not getting help. You're kind of in limbo. It's really not a great thing. And it leads to boarding, as I was mentioning before. And the definition of boarding is basically just people who are already considered that all their emergency medical conditions, except for psychiatric emergency medical conditions, have been ruled out. And they're now just waiting for usually a transfer to an inpatient psychiatric bed. Depending on which hospital it is, they might be in specific holding rooms. They might be in a small individual room with a one-to-one sitter who's at arm's length away, who's there at every moment just to make sure that everything is all right and they're not trying to harm others or self. Or what we see all the time, which is kind of in this photo here, which is people who just get kind of strapped to gurneys and placed in the back hallways of the ER and can stay there for long, long hours, sometimes days, in some unfortunate stories, even weeks. And their basic only contact is people coming by every once in a while, take their vital signs, people bringing them a meal, but they're not getting any treatment. And so not only just that unfortunate situation, but the ED environment itself, where there's flashing lights, there's strange noises, there's uniformed personnel running around, things are very hectic. Imagine if you're already despondent or very paranoid, that might make your patients, make your symptoms worse. And indeed, there's several good studies that show the standard psychiatric emergency patient who gets stuck in an ER, they're more likely that their symptoms will get worse rather than better while they're kind of stuck in that ER. And that's compelling reason that we should be looking at things differently. It leads to overcrowding as well, and that compromises other patient care that we see. So add on to all of this 988, which is maybe one of the most wonderful developments nationwide in my career. It used to be that if you wanted to call somebody, you were in crisis, you were actively suicidal, you'd actually have to look up the number or find it somewhere. There's this national suicide hotline, 1-800-273-TALK, which was great for what it was. But I mean, imagine you're in a suicidal crisis and you're like, was it 1-800-274-TALK? And getting the wrong number. I mean, that would be really frustrating and not helpful. So in the last couple of years, we've been fortunate enough that the federal government has authorized 988 as the intro to the crisis system. And that's as easy to remember as 911. And that's a wonderful thing. 988 can, get you, whether you're suicidal, whether you're having a psychiatric crisis, and get you connected immediately, just like we would 911 if your house was on fire. So everything about this is fantastic. And I've been so excited since 988 became a reality. The one little caveat here in terms of what we're talking about is that because 988 is doing such a great job, it means they're identifying more people who are at risk and identifying more people who are having psychiatric crises, psychiatric emergencies. And even if only a small percentage of those folks that they're newly identifying are, required to come to a hospital ER or a hospital psychiatric campus, that means more than there were before. And it's just kind of that simple. Wonderful thing. We love 988, but recognize, as those of you on the call who are hospital leaders or hospital C-suiters, anybody who's involved with, medical hospital situations, these numbers are going to continue to go up. It's a good thing because we're recognizing and saving lives, but it also means you have to have a greater concept that you're going to have more need for more capacity, because there's just more people out there in crisis right now than we've ever seen. So what have people suggested as a way to resolve the boarding solutions that resolve the boarding situations that we've been having? So what this is actually what first started me on the journey towards EmPATH, is that I would see TV news or the New York Times or somebody like this talking about all these psychiatric emergency patients stuck in ERs. And remember, I've been working as in a dedicated psychiatric ER in Oakland, California for many years at this point. And I would read these stories in the newspaper, and they would say, like, look at all these people who are stuck in ERs. It's like 30% of the patients in this major famous ER, Johns Hopkins or University of Pennsylvania, they have dozens of patients who've been stuck here for days. And so they're all waiting to be transferred to an inpatient psychiatric hospital. And then the reporter would go, well, back to you, Jim. Clearly, what they need is to build more psychiatric hospitals because they've got too many people waiting for those beds. If they just built more beds, then that would solve the problem. And I would hear that and I'd say, like, no, that's not the solution. All you're doing is kicking the can down the road and saying the next step should have more beds. But it's ignoring the kind of the heart of the problem. If you come into the ER and let's say you have an asthma attack and you're short of breath, can't breathe, please help. If we treated you the way that we do a psychiatric emergency, the staff would go, oh, come along, sir. We've got a great place for you to sit here in the back of the ER. We're going to start trying to call around and find you an asthma hospital. And if you just sit tight for a day or two, we should be able to get you to an asthma hospital. So just relax. Everything's going to be fine. That sounds really ridiculous, right? But that's exactly what we've done historically with psychiatric patients. So if the New York Times says we need to have more inpatient beds to move those patients to that, what they're ignoring is the same thing what we were doing in that vignette about asthma patients, which is, hey, how about institution doing an evaluation, instituting treatment, putting people in a situation where they feel supported, calm, able to get better. And you know what? If we do that, the vast majority of patients don't end up needing those inpatient psychiatric hospitals. In fact, it's roughly equivalent to if we had everybody who came into the hospital with chest pain saying, if we just admitted to the hospital every one of those patients, right now we'd all be on a webinar and why are there not enough med surge beds in America? We don't do that because things like asthma, things like chest pain, we're able to stabilize, treat the great majority of them in that emergency level of care and get them to a less restricted environment, which is usually getting them back home. We can do the exact same thing with psychiatric emergencies. And indeed, what we've seen from research across the board internationally is the great majority of psychiatric emergencies can be resolved at an emergency level of care in less than 24 hours if you use proper treatment and a proper environment. It's really just that simple and that analogous. So what we've been doing is thinking that anybody who comes in needs to go somewhere else, when actually we can fix this problem right at that emergency department level of care. And that's what the EmPATH model is all about. Realize that EmPATH, I know it, at least I think it sounds like kind of snazzy. It's a great acronym, but it's in the academic literature. It's an academic acronym that is for a specific model of psychiatric emergency care that is affiliated with a hospital ER. It's not copyrighted, it's not trademarked. Anybody who wants to open an EmPATH unit across the world can do so. They don't have to ask any permission. It was created with that in mind. And if you don't believe me, you can believe Wikipedia, which has a wonderful section on empath and empath units, which they also recognize are a generic term and part of the literature. So empath units are overall based on what are known as the 6 goals of emergency psychiatric care. Sometimes those are known as Zeller's 6 goals. If you look in the literature, you'll see in multiple spots that you can find out about Zeller's 6 goals of emergency psychiatric care. And the funny thing about it, you may remember from the introduction that my name is Zeller too. And you know what the crazy thing about the connection here is that I'm the one who originally wrote these and published these about 15 years ago. So little self-plug, sorry, but it's kind of funny when I see Zeller's 6 goals in literature, because they were something that I put together years back, and I think they've really continued to prove themselves, and super quickly, because I could spend a whole hour just talking about these goals. But how is this important, what we're talking about? Psych ERs, hospital ERs, empath units. When somebody has a psychiatric emergency, how can we help them? What's the best way to do so? First off, we want to make sure that we've ruled out any kind of non-psychiatric medical emergency and make sure they're otherwise medically stable. Why is this a big deal? Based on what study you look at, between 10 and 25% of people coming in with what appears to be a psychiatric emergency, it's actually due to a non-psychiatric condition. And sometimes those can be life-threatening, especially head trauma, bleeding inside the brain, poisoning, overdoses. So we need to really take a good look at people and not just say, oh, they're just psych, and push them into a corner, or have them see somebody who doesn't even know how to take a vital sign. No, these are medical conditions. Remember that above the neck is still part of the body. Your brain is an organ too. It's affected by things that are going on in your body. We need to do overall physical, once-overs before we think you're ready to begin that psychiatric care, because we don't know at first if that's even a psychiatric condition. Maybe it's due to something else. When we know that somebody is medically okay, then we want to rapidly stabilize that acute crisis. That's so important. Remember that the people we're seeing are suffering. It might be the worst day of their lives. And it may not be as obvious to us as somebody coming in who's been in a car accident with a broken bone, or who's clearly having chest pain or shortness of breath. But you know what? A psychiatric emergency is very similar to that. We wouldn't wish on our worst enemy the kind of symptoms that a psychiatric emergency might be. What is it like if you feel like you so hate your life and do not want to live another moment? You don't want to take another breath of air. How must that feel? Is that a medical emergency? I think so. How about if you are hearing auditory hallucinations in your head, literal auditory hallucinations? We can see on a brain scan that it lights up the part of the brain that your brain would show, listening to me right now, that they're literally hearing voices, and those voices are giving them commands, telling them to hurt people. And they don't want to do it, but the commands are very strong. Is that an emergency? I think so too. But I've had colleagues say, Scott, you make some good points here, but here's the thing. When we're working in the hospital, we are able to do blood tests that show the presence of conditions. We're able to do x-rays that show the presence of conditions. And your psychiatric emergencies, you don't have any of that. And I will agree with them, and I will say, you're right. We don't have a blood test or an x-ray to prove somebody's having a psychiatric emergency. But you know what else we don't have a blood test or x-ray to prove in the ER? Pain. And we all believe pain exists. We can see pain exists, and we want to help people with pain. And so maybe we should think of somebody coming in with a behavioral health emergency as the equivalent of the worst headache you've ever had in your life. And if somebody was like, oh my gosh, head splitting, please help, you wouldn't say, oh, have a seat, we'll help you in 8 to 10 hours. You'd be like, oh my gosh, you're in pain, we need to help you. And that's the way we need to look at psychiatric emergency patients as well. And when we do that, we want to avoid coercion. We want to instead form a therapeutic alliance. Historically, too much emergency psychiatric care has been sit down, shut up, we're going to put you in restraints, we're going to forcibly medicate you. Wow, that's a great way to screw up a relationship with your patient from then on. How about instead we are empathetic, we're understanding, we reach out, we say, hey, tell us what's going on. And if we hear some things, we can offer medications voluntarily that are willingly taken, saying like, hey, it sounds like maybe this medicine's worked for you in the past. Do you think maybe we should try it again? How different is that than putting somebody immobilized into a bed and forcibly medicating them with needles? Along that same lines of avoiding coercion, we want to treat in the least restrictive setting. Locked into a hospital unit is a very restrictive level setting, even more than that being in physical restraints in that setting. We want to always be treating in a direction towards away from those. So if we can do a good enough job that somebody can go home, be free to come and go as they please, that's the least restrictive setting. And I think that's what most of us would want at most times. And hopefully we can do such a great job with our emergency psychiatric care, people can go to least restrictive settings. And then when we've done a good job with all those previous 5 things, we can put together a really good disposition and aftercare plan. So hopefully we can do what I've often said, if we do the best job in the world in emergency psychiatry, we'll put ourselves out of business because we will make people in such great shape that they won't get into a psychiatric emergency again. Unfortunately, we're not at that stage yet, but if we can do a really great job setting people up with aftercare, safe housing, making sure that they have a provider, therapist, a social worker, case manager, other people on the outside, and we'll work together with them, we really actually prefer to have less business in the future if we know that it's because we did a great job with our patient and helped them not have to get into an emergency psychiatric condition again. So this leads to EmPATH, and I know I'm always the clock always is a little faster than I am. But EmPATH, as I said, it's an acronym. It stands for Emergency Psychiatric Assessment, Treatment, and Healing. The neat thing about the acronym is that it goes in the direction of how we do things in that unit. Somebody comes in, we do an emergency evaluation, the emergency psychiatric assessment. We hopefully initiate a treatment plan as quickly as possible. We want our newly arriving patient to see a psychiatric provider within minutes after arrival. Then we start a treatment plan, which hopefully will lead to healing. And we usually have up to 24 hours, in some states up to 48 hours, to help this person get back on track, feeling like they're themselves again, ready to go, and we're there for them. And everywhere that this model has been set up, and there's several dozens around the USA at this point, the average is 75% or more of the people they used to think needed to go to an inpatient hospital bed actually get better and can go out to the community, usually back home in less than 24 hours. So what's so different about it? EmPATH is actually a designated psychiatric ER. Sometimes people say, oh, I think we know this. If you're in the ER, a counselor will come see you and they'll say, you go to the inpatient, you go this way, you go that way, and you're somewhere in between, you go to EmPATH. That's not really what it is. EmPATH is supposed to be the destination for people with acute psychiatric symptoms. So like we were saying, the problem sometimes with the community crisis centers, as wonderful as they are, is that they aren't going to be able to work with the higher acuity patients. We want those patients to go to EmPATH because that's what they're designed for. EmPATH is designed for high acuity patients, people who otherwise would be waiting in line for an inpatient bed. So when they come into the ER, rather than having them sit in the ER, the thing we're trying to avoid, we know it's claustrophobic, we know it's frightening, and we want to get them to some more appropriate location. So let's not delay there and move everybody who the ER doc feels is appropriate to the EmPATH unit. And that's where we're going to do our initial psych eval. That's where we're going to determine a treatment plan and where we're going to hopefully see all psychiatric patients, do a treatment, then have them under this gentle, constant observation, do a re-eval, which far more often than not is going to say, hey, they're doing much better. Let's start planning a discharge. It's this wonderful, calming, healing environment, and it's completely separate from the medical ER, although they're quite commonly just next door to the ER or through a doorway from the regular ER. Here's how they're designed physically. It's kind of like a big group slumber party, if you will. There's a bunch of folks in the same room together. Everybody gets to choose their own sleeper recliner chair. They can sit up in it and engage in one-to-one individual therapy. They can participate in group therapy, or if they like, they can fold it flat. It becomes a bed. They can grab themselves pillow and blanket without having to ask anyone's permission, and they can take a nap. It's that kind of situation where you're going through what might be the worst day of your lives. We're going to make things as easy for you as possible. And if you feel like it's time for a nap, great. If you want to come up and play a dominoes game with two of the other patients and two of the nursing staff, fabulous. If you want to walk around the unit because pacing makes you feel better, great. Whatever it is that reduces the stress, the anxiety, the things that were exacerbating your underlying mental health condition, that's what we want to do. We want to have a beautiful room that feels very home-like and where the ceilings are high and we've got natural sunlight and the decor is soothing. The room is designed to for socialization and therapy, and that can be in between patients and each other, or it can be staff. We want our staff to be intermingled around the patients rather than being behind some kind of fishbowl or glass barrier, where everybody's in this together and we're having this like a day of support where human interaction, those first 24 hours of personal crisis are so important for somebody who's having a psychiatric emergency. You get other people around who understand what you're going through, people who can work with you, people who are there for you. It makes a world of difference. And so you usually have like a social distancing of 40 square feet around each recliner, but overall there's 80 square feet per patient. And that's that extra room for recreation or the dining tables, or maybe there's an outdoor area you can sit and meditate in the sunlight. It's all these great things. And this is the same population that 25% of them or so, if they are in the medical ER, would end up in physical restraints and forcible medication. That same population with 25% would end up in restraints in a regular ER. In the EmPATH unit, it's usually 1 or 2 out of every 1,000 patients. So compare 250 patients out of 1,000 to 1 or 2 out of every 1,000, and you can see the difference that it makes. It's all about the difference in the environment, the difference in the immediate approach, and difference in starting a treatment plan right away and having a supportive cast around you. Here's some pictures that you can see some of the existing programs around the country. Actually, the one in the lower right is not all that far from you. That is at Fairview in the Minneapolis area. The one on the upper left there is at the University of Iowa, a wonderful program that has created some of the best peer-reviewed research in major journals out there on the EmPATH model. I'll mention that a bit in a moment. But you can see how some of these are. The one on the left hand there is actually at Centric Care, which is also in your state. And you can see how these are all set up to feel spacious, to feel positive. How different does this look than the typical ER where people are in different curtained off cubicles or somewhere with a security guard or a sitter? Doesn't this seem more like a place that, hey, I could be here for a few hours. This looks pretty comfy. And we want to get in natural light and all the kind of things that make people positive. There was a great feature on EmPATH units done in the magazine that's known as The New Yorker, a real famous popular magazine. In July of this year, they did a wonderful feature study on the EmPATH unit at Fairview Southdale, the University of Minnesota Hospital. And the author from the New York Times, New Yorker, I apologize, who is a physician himself, and said he wished there was an EmPATH unit at his hospital. But his quote I had to pull for you here because I think it's so on target, where he said EmPATH units' real innovation is a structural shift in how we think about space and time. We usually consider drugs, devices, and procedures as what we think of medical care, but physical spaces can be therapeutic too. And that's so much about what EmPATH is about, is that changing that physical environment so that people are going to do better and feel more comfortable. We have all kinds of different personnel who are in there, be it psychiatrists, nurses, social workers, case managers. We love peer support specialists, people with lived experience in mental illness. They get training and license, and then they are fantastic people working in EmPATH units along the lines of, hey, you're going through a tough time. I've been through it too. Let me help you get through it. We'll do it together. And they're worth their weight in gold. For the patients, it's a calming environment. It's a supportive environment. They get multidisciplinary treatment team. The fact that we're not trying to make a decision when you first walk in the door on whether or not you need an inpatient bed, but actually we're going to give you a number of hours to see how you respond to the treatment plan, constantly observe you, constantly reevaluate you, but all in a gentle way. What we find is that the great majority of folks keep getting better, and we're not stuck with an idea like, oh, 12 hours ago we said they needed to be hospitalized, because now we can say, hey, look, they're doing much better. Let's start planning how to get them back home. As I mentioned, almost zero restraints, and everybody gets seen by a psychiatrist within the first few minutes of arrival. Our goal in EmPATH is to change an emergency patient into an outpatient. That's what we're trying to do. And hopefully, if we do a good job, we won't get them into an emergency condition again. Here's some quick success stories from across the country. Here you can see stars of EmPATH units that are either currently in operation or are in development and should be opening up soon. The stars just keep on growing, and it's really gratifying. The most amazing results that we've seen to date is probably the most prestigious journal in emergency medicine. It's called Academic Emergency Medicine, and 11 months ago they published their feature article. It was their editor's pick, and it said EmPATH unit decreases hospital admission, but they did not, in that short title, tell all of the wonderful metrics they found out. This was a study of the EmPATH unit at the University of Iowa, which kind of like the main medical center for 100 miles in any direction. And they compared the same population 6 months before the EmPATH unit opened compared to 6 months after the EmPATH unit opened. And here's what they found. The patients ended up staying in the medical ER, the emergency department, from over 16 hours on average before, now under 5 hours. That's a 70% reduction. The number of people they saw who needed to go to inpatient, again, remember, the vast majority of patients can have their conditions stabilized without needing inpatients. They dropped inpatient admissions by 53%. Once again, going down to that 1 in 4 patients like we see so often elsewhere. But here's some interesting things we didn't even expect, that we were so amazed when we first saw these wonderful folks publish this article, that if you were discharged from EmPATH as opposed to being discharged from an inpatient psych facility, if you'd been discharged from EmPATH, you were 60% more likely to go to your first appointment with your outpatient psychiatrist, your outpatient case manager, your outpatient provider. And if you're doing that and you've changed your mindset, like, hey, I want to work with these people, that's going to dramatically reduce the need for you to get into a psychiatric emergency again or have to come back to EmPATH again. And you know what? That's exactly what we saw. The 30-day return for patients to the ED after EmPATH decreased by 25% over those same folks who would have been, coming back after an inpatient visit. And that so answers the question when people say, hey, your length of stay is under 24 hours. Aren't these people not staying long enough and they'll just end up coming back a few days later? And the answer is no. They actually end up doing quite well in the community and not coming back at all. Isn't that a win-win across the board? We're even able to show that they save money for the ER by getting rid of the need for these coercive sitters and these coercive interventions. Getting people in this open, supportive environment is much, much better. And even that 1 out of 4 patients who still needs to go to inpatient, they arrive on that inpatient unit with a day of treatment under their belts. They already have medication plans decided. It's facile for everybody. It makes things great for the patient and the staff. And that results in usually a shorter length of stay, and they can get back home and back to, engaging in their lives that much more quickly. I know I've only got a couple more minutes and I want to save time for questions, so I'm going to rush through these really well. Another place in Minnesota here that we've been talking about, mHealth Fairview, they're actually only admitting 17% of the patients they see. And that is compared to national averages of about 60% with the same population. It's just amazing. That's what an EmPATH unit can do. You're saying, oh, well, these are all big university hospitals. Well, how about a small rural hospital like the Billings Clinic in Montana? They opened up an EmPATH unit, one for both adult and kids. And I'll tell you real quickly that the biggest growth right now in those, dozens of empath units being developed around the country. One of the hottest things is child and adolescent empath units. The one in the Billings Clinic proved that it could be done, that you could actually have an adult and an adolescent unit side by side with a shared nursing station, but a wall so that you don't commingle the adults and the kids. And they just had the same wonderful things that we talked about. Recidivism there dropped 50%. They were saving tons and tons of money for the hospital. The ER length of stay dropped precipitously. Everything great. Same thing, go from a small rural area to big city, downtown Los Angeles, California. They opened up an empath unit there. They were able to discharge 81% of the people they saw who were all on involuntary psych holds. So by definition, if they hadn't stabilized them, 100% of those folks would have had to go to an inpatient psych bed. That was the state law. But the empath unit was actually able to take the same patients and stabilize 4 out of 5 of them and avoid inpatient hospitalization. Average length of stay, 16 hours, thousands and thousands of visits. Again, you see safety, pretty impressive. Sacramento, California. We show this real quickly because of a couple of things we haven't talked about, but they used to be one of those places that had people stuck in the hallways for hours. Their average length of stay for people on gurneys stacked up in the hallways in what they called their hallway of shame. Their average length of stay was 33 hours. They opened up an empath unit. Within weeks, they dropped that to 19 hours. Within 2 months, it was 7 hours. Now, their average length of stay is total in the emergency department of 3 hours. That's where all the evaluation, that's doing labs, it's doing everything else at 3 hours. Actually, once they say they're okay and they're ready to move to empath, it's less than an hour. And 80% of patients discharge home. Here's something we haven't talked about much: patient satisfaction. Imagine your day started being brought in by police in the back of a squad car for the crime being suicidal, and that's how your day started. But then you go to an empath facility and you actually do well and you get to go home. Can you imagine 85% of those people said that they had a good day after all that? That's incredible. So federal agencies have said empaths should be everywhere. There should be at least one in every mental health system. It's a cost saver for Medicaid and Medicare because every time we avoid an inpatient psychiatric hospitalization, we're saving $10,000 to $20,000 from Medicaid, Medicare, private insurance. If the average stay in an empath unit is $2,000, $2,500, we're saving, $36,000 for every $8,000 Medicaid pays for empath. And that's documentable savings. That means that they should really be looking at these. And maybe the solution to the shortage of inpatient beds first needs to be, let's get more empath units so that we're doing a better job for people up front, rather than holding them in an ER for 3 days, transporting them 100 miles away to an inpatient facility where they get checked in for the night and they don't see the doctor till the following day. Okay, you've already had 4 days with no treatment, no intervention, and just frustration. Of course, people aren't going to do well. What if you start treatment and intervention right away? Guess what? 75, 80% of people do better and can go home. That's why both the state of California and the state of South Carolina have given out now a total of 25 different grants of $3 million each between the two states, specifically to build empath units in their states. And there are different levels going on, but I think within 2 or 3 years from now, you're going to see at least 100 empath units across the USA. And I hope that's one like that old commercial, and they told 2 persons, and so on and so on and so on. And pretty soon they're everywhere. Thank you so much. I'm happy to take questions.
Okay, right now there's just one question for you. It's from Angie, and this was kind of during when you were talking about the open format and stuff where they had the different rooms and stuff like that. Her question is, how do you manage client privacy rights in this model? And again, that's more of the the open room, unless I'm misunderstanding you, Angie. I believe that's what you're talking.
No, it's a great question. It's one that comes up quite often. So a couple things. Realize that the alternative to this model is not some luxurious private space where they'd be in, but far more commonly strapped to a gurney and parked in a hallway among 4 or 5 other patients who are just lined up in the hallway with staff, patients, outsiders walking by them all day long. Probably the least private situation that you could be. The idea behind EmPATH is that when we have a bunch of folks together, that first 24 hours of being in a crisis situation, human interaction is so important. And seeing other people around and knowing that other people, you're not the only person in the world having a tough
We're a
time,
community
that you're all in
hospital.
it together.
Limited.
And that's a really positive thing. But in terms of privacy, every EmPATH unit is going to have several rooms that are set aside specifically for private conversations, especially when your psychiatrist comes and is ready to do your interview and evaluation. You're not going to do it right there sitting in your chair with everybody around you listening. You wouldn't want to do that. You get moved to an interview room, and then you can have that private discussion. And everything you say is confidential, and it's really good. But then when you get back out there, the bigger room, maybe you're doing things more like, think about an inpatient psychiatric facility. There's group therapy, there's group activities, there's recreational therapies, all these things. We're just kind of combining that all into a much shorter stay in the same room. There's still the same emphasis on privacy, but there's still the same encouragement to participate in a larger group, because things tend to go well in that group setting, especially when you have the knowledge that you're not alone. That's where we see a lot of the beneficial outcomes arise from the EmPATH model.
Okay, and I just wanted to remind people that there's the Q&A at the bottom of your screen. It should be next to your participants, depending on what format you're using. Or you can just click on there and type in a question. So there's another question. This one's from Tom Gaffney. It's can hospitals make a profit?
So what we always tell hospitals is that don't think of EmPATH as a profit center. That shouldn't be why you're creating it. But from everybody has to look at financials, and it's a realistic thing to look at. And you certainly can't ask a hospital to do something like saying, hey, why don't you start losing money? As I mentioned in that study at the University of Iowa, not all that far south from you, they were able to identify that in the first year of the EmPATH unit alone, the EmPATH unit was able to save the ER about $900,000 in less need for sitters, in fewer patients leaving without being seen, in better bed turnover, better movement of patients moving into those beds. So there's already financial benefits to having a better place for your mental health emergency patients to go for better care in a better location. That being said, there are good ways to reimburse these units in Medicare, Medicaid, and in private insurance. And so the goal is shoot for this to be something that breaks even. We want you to be able to say, look, this is self-sufficient, so that the CFO doesn't come after you and say, like, why are we operating this program? If you're self-sufficient, you are going to be saving tons of money elsewhere in the system. It's going to be less expensive in your ER for these folks. The inpatient unit is going to have far fewer admission denials, because you're not going to be admitting people inappropriately. That part of the system is going to save money. The ER is going to save money. And if you're really good at what you're doing, you might even be able to make a small margin operating your EmPATH unit. We do know of places that have been able to do it. Then again, what we say is your goal for this should be that it's the right thing to do, and that there's no reason that it can't be at least self-sufficient, and maybe even make a little bit for the home team, but you're also going to see wonderful economic benefits throughout the hospital if you have them. So it's really win-win, win-win-win across the board.
Okay, thank you. There's a question from Lynn. How are hospitals managing the staffing crisis to be able to provide immediate psychiatric care in an ER setting 24/7?
Yes, that's such a great question, and it's so on target that there has been a big staffing problem nationwide with credentialed providers. I think we all know how difficult it has been the last few years to get enough nursing staff, and how that can be a problem. Some places have come up with creative staffing solutions. A lot of these units are under the purview of very specific state laws with staffing ratios that makes it that much more difficult. And I would be lying to you if I said that there weren't EmPATH units that have struggled with this whole situation with staffing. However, that being said, we've seen a lot more optimism around this in the past few years. And there's some things we know that are really great. One is that if you're interested in the first part to work in a situation like this, work in emergency psychiatry, work in an empath unit, and you go and start working there, for many people like myself, you're like, wow, this is my dream job. I love doing this. I can get up in the morning, go to my shift, meet somebody who's having a just really awful day, maybe the worst day of their lives. And by working with them during that day, before it's the end of my shift, they are shaking my hand and saying they're ready to go and thank you for the help. And wow, isn't that a good enough reason for me to want to get up and go to work the next day? I mean, it's the most gratifying thing in the world to see people get better before your eyes. So a lot of the staff who do come in, there's not a lot of transition. A lot of them come in as like, wow, this is where I want to be. And I feel like I'm making a change in the world. And so you get a core staff that's built around that. And that's how you end up fully staffing units. There is, as I mentioned in that one slide, you know, that there's important roles for nurses, social workers, peers, psychiatric technicians, you know, psychiatric providers such as psychiatrists and psychiatric nurse practitioners. If you're in a place that's a little more difficult to find a way to staff with psychiatric providers, we've seen great success in operating these units almost entirely or mostly by telepsychiatry. And because you know, we're working with folks and doing face-to-face interviews on telepsychiatry, and the psychiatrists don't really need to pick up a stethoscope, we're able to make that work. And it's one of the professions of medicine that you can actually do virtually because we don't touch our patients in psychiatry. So there's a lot of good ways to do it. I see a lot of empath units that use a mix of on-person providers and then during the off hours have on-demand telepsychiatry. That's a way to make it affordable and also to guarantee that you've got enough staffing. I hope that answers your question.
Okay, thank you. Another question is, how are peer supports being implemented within the empath units?
Peers are just fantastic, and as I mentioned before, worth 10 times their weight in gold. With the way that most commonly we use peers is to be as almost in a role at some point where they're kind of like a sponsor in LA. I mean, a sponsored AA. I'm sorry, sorry to slip there. Where they can meet with somebody and say, hey, you know what? You're going through a crisis. I did this 2 years ago. Talk to me. I can share my experience. I want to hear about what you're doing, and have somebody there that's at that same kind of nitty gritty where you're both understanding what's going on. It's been recent. That's enormous, and that's so helpful and supportive for patients. But the other thing that peers can do, which is amazing, which is they're often so much far more capable at than the average nurse or doctor who's on the unit, is that they know the system. They've been on the streets. They can say like, hey, if you're going to leave here, here's a place that I know you can go that is got supportive housing and they've got open spaces. Here's a place that if all else fails, you can always go, and they have a hot lunch, no questions asked, every day at noon. You can go there. Here's a great place where the lines for getting your refills on medication are non-existent or short, and kind of somebody who kind of knows the system and can help people out. And wonderful thing that is. And it gets back to one of the basic idea of empath, which I mentioned a bit, but I don't think often enough, which is we want to change our emergency behavioral health patient into an outpatient. And that means off the hospital grounds, not hospitalized, doing so well that an outpatient is somebody who maybe comes in for an annual checkup or something like that, or has a reason to come in for a regular medical visit, but they're not coming into the ER. They're not coming in involuntarily. They're not coming in under police custody. We want to change our person into a happy, healthy person who's enjoying life, who's in the community, is contributing to the community, who feels part of that community. And all we've done is help them a little bit when they had a bad day. And we've all had bad days, and there's bad days when maybe we break our collarbone or have really bad upper respiratory infection, and we get some help from the ER. And then we find out that that was good help. And then a little while after that, we're doing better. We can do the exact same thing with behavioral health emergencies. And what's so neat about that is that helps to eliminate stigma as well. Because if we think of that there's stigma around behavioral health, mental health issues, you know, nobody is ever saying, when they tell you they have diabetes or that they have a sprained ankle, they're not embarrassed to tell you that. But, you know, everything above the neck and the brain is part of your body. And we shouldn't be embarrassed to say that there is something we've had a little bit of trouble with that recently either. We start thinking of parts of the body as medical conditions, whether it's above the neck, below the neck. Every one of us needs help in some area at some time. And just to recognize that maybe sometimes that's going to be above the neck, nothing to be ashamed of, just another kind of ailment that affects people. And if we can work with them, help them to get better, and let's create that window of time where they're outpatients for years and years and years and don't have to come back to the hospital and don't get into emergency condition or a life-threatening situation again. And that's our goal.
Okay, thank you. So, in your experience, what has been the biggest challenge that rural empath units have faced?
I think yeah, that's a great question. And there's a number of rural areas that are constructing empaths right now. There's some that should be opening up within the next few weeks, which is really exciting. I think the biggest challenge that a lot of them have seen is that you know, people are just really spread out, and it takes a while for people to get to the kind of help that they need. And especially in these spread out areas where you might be 50 miles away from the nearest city of 10,000 people, and that's the big metropolis for you. That means if you are having a behavioral health emergency, it's going to be a long time to get you there. And once you're there, where do you go once you're discharged? Because, hey, we got 2 hours between you here and there. And where do we get enough staff to work in this area? Where do we get, you know, everything, all the resources and things put together? But what we've been seeing, which I think is really exciting, is the idea of a concept of a hub and spoke model, which is let's take, you know, city of 10,000 X, which is kind of all the roads lead there for 100 miles in each direction. So it's a place where anybody having any kind of mental health crisis, even just mental health concerns, can come from anywhere around the region, get there, get the help they need. And if it's operated as a regional collaborative situation with the area counties, if maybe it's divided up like that, or just the area section of the state, the way that funds are distributed, that maybe you can say, hey, this is where things are going to be done here. And we don't have to have a situation where anytime somebody comes to a critical access hospital with psych conditions, we have to call a sheriff to drive them 400 miles to the state psych hospital, which is not something I'm making up. I've heard that story in numerous states. So wouldn't it be greater if we had these regional hub and spokes? I'm sorry. They're not going to be super prominent. They're not going to be super busy, but they're going to serve this incredible need that so far has not existed for these populations. And knowing that there's a place to go, it's something that we often say. You know, it's one thing if you're able to do great work and let's say have a fantastic mobile crisis team who can go out and stabilize and help solve problems in your home or in your front yard with people who are having a tough day. But sometimes people are going to be having a bit more than that's possible for that crisis stabilization team. And then it's to the ER. What if you have an empath ER they can go to instead? If you look at all the research or all the philosophy around you know, these kind of mobile crisis situations, it's a place to go. And if they have a place to go, not dropping them off at the ER because that's the only place they can, but dropping them off at an empath unit where they've been prepping them. They know what to tell them about. They're saying, here's what's going to happen next. And you're going to meet some good people and they're going to be there for you and help you. as opposed to like, well, we're taking the ER and it'll be on them next. They'll let you know what's going to happen. Well, see that difference? Having a specific place to go if you're having a psychiatric emergency, it's almost like if you know you've got a specific labor and delivery unit, that's where you want to give birth to your impending baby. You know, you don't want to just go into the ER and have them say, okay, well, you're here. Why don't you just lie back and have the baby here? No, it'd be much better to be in the labor and delivery unit where you've got obstetricians and labor and delivery nurses working with you in an appropriate environment for that experience. We can do the same thing with psychiatry. It's very simple to create a unit like EmPATH. There's very little need for walls, very little need for equipment. So you can make cost-effective implementations of these units, in just about any kind of building that's got some extra space. And that can be rural, it can be urban, it can be academic, it can be in a community setting. The neat thing about the models, we see the same kind of outcomes. About 3/4 of everybody who comes there gets better and are able to go home in less than a day. That's whether it's rural, urban, academic, or community.
Okay, we have 5 questions in there in about 14 minutes. So I don't know if you want to shrink your answers down or how you want to do that.
Oh, no. Okay. Now that I know there's that much better. I was
Okay.
hoping to be complete and
Yeah,
make sure everybody
yeah.
understood, but I'll make them faster so we can get them in. If
Right.
that's okay. I'm not boring them.
Yeah. No, these are great.
I don't
So
know.
another question is, what sorts of alternative medicine is being offered in the EmPATH units, like aromatherapy, acupuncture, skills teachings, things like that?
That's a great question. And the one thing that's neat about EmPATH is that EmPATH is a model and it's not a regiment. It's not a franchise, let's say. You know, you go into a McDonald's in Pennsylvania, it's probably going to look the same and have the same menu offerings as a McDonald's in Nevada or Oregon, right? You know, it's McDonald's. EmPATH's not that. EmPATH is a basic set of concepts and it's a model and it's something to build around. The basic concepts of EmPATH are creating an open, therapeutic, home-like environment where people feel safe and comfortable and relaxed and able to work on stabilizing their acute crisis. 2, to see an emergency mental health provider as quickly as possible to have a treatment plan started. And 3rd, to not make a decision too quickly, but give people an opportunity to see how the treatment plan works, do observation, constant reevaluation, and try to determine disposition once you see how people are responding to the treatment. That's really, those 3 things are basically the core of the EmPATH unit. And that means you can do any iteration of it and add anything to it that you'd like to do wherever you do your program. So we've had some wonderful collaborations with peer support specialist organizations who said, hey, we've got some ideas on how you could do things differently. What about if you had this for a therapeutic room where there was a wall that had films of nature going on, there where people could go and sit in there in a beanbag chair and they could relax and they could see that. And it's like, wow, that's fantastic. I love that idea. Go ahead and try it. Let's see how it works. If you go to the EmPATH units around North America, I think the one thing you would be able to say is if you've seen one EmPATH unit, you've seen one. They're all different. They've all figured out their own different idiosyncratic approaches. Some of them have wonderful outdoor healing gardens where the individual patients can go out to and sit and meditate or reflect. There's, you saw that one picture where people had a mat that they could do stretching and yoga style exercises, things like that. You can't set down a mat in the middle of the floor in the typical hospital ER. I think security, or at least the janitors, would be by soon saying, get that out of here. But in EmPATH, it's fine to do things that might be for meditation or mindfulness or things like that. There's activities that go on that are different depending on which site you're on. They might have a full slate of activities where there's therapy groups and living skills groups and 12-step programs and grooming and all kinds of different things that are interesting and available, and you're not required to go to them, but they might be an interesting thing to do, even if you're just looking to pass the time. And hey, here and there, you might learn something that will be beneficial too. So there's no set and hard, fast rules that empath must be this. Instead, we say, hey, why don't you take this basic idea and do what you'd like with it? See, innovate, do interesting things that might make it better. And maybe not all of them are going to work great, but then that might lead to do something else better. And the more that we've seen the existing empath units, which is an idea that's only been around for about 7 years now, the units are continuing to innovate, come up with new ideas. Wonderful people work in there who want to do the best for their patients, and so they come up with different ideas. And so that's where you would see some of the things you're suggesting. There's places out there that have just about everything A to Z going on. If you want to look around, I don't think any one of them has all of them, but each different place is trying different things, and those incubators of innovation, and it's amazing to see. And every time we hear something wonderful, we suggest maybe the next place we're working with might want to consider it as well.
All right, thank you. And I don't know if this is more of if this is a state or national, but can a psychiatric nurse practitioner fill the role of the psychiatrist?
Yeah, absolutely. And you're right. It's a state by state thing. I found that psychiatric nurse practitioners are fantastic working in empath units. They often have a much better recollection of their medical part of their training than some of the psychiatrists who've been out of practice for 20 years or so. And, empath units, you definitely need to know a little bit of your medicine as well as your psychiatry, because somebody might come in with a high blood pressure or racing pulse or dilated pupils, or be kind of incoherent or unsteady on their legs. And are you going to be able to take a look at that and diagnose that and try to work with them? I think most nurse practitioners are a little more comfortable with it, doing that than some of the old timer psychiatrists, which would probably be people in my age group. So they're wonderful, and I think it's a great job for psychiatric mental health nurse practitioners, and we strongly encourage them to consider going into it after graduation or considering it as a career. You're right in, though, that some states don't allow them to operate independently at this point. In that case, you would set up the program where they have a supervising psychiatrist, but they can still be doing the frontline work. There's no reason they can't do that. The psychiatrist is just their supervisor. Other states that are more enlightened, it may be that the PMHNP is just able to work autonomously, and that's fantastic. As we mentioned before, it can be hard to fully staff these units because we need to operate 24/7. This is not a 9 to 5, 5 days a week program. This is an ER. It's an extension of the hospital ER. We need to be staffed around the clock. And as far as I can see for the future, I think, and what we're hoping for, is that the nurse practitioners are going to become really predominant in that role, because there's a lot of great ones coming out of different programs in the country, and we would love to engage them into working in empath units, because I think they do really good work.
Okay, and I believe I know the answer to this, but are empath units housed within an existing hospital or established at a separate location?
So it's actually, the answer is yes. And there's actually something called the FGI guidelines. And every 4 years, that stands for Federal Guidelines Institute. There's an organization that puts together all the rules and regulations that most states in the US accept for their licensing, design, and construction of healthcare facilities. As this guidebook comes out, and it's a work of love of hundreds of professionals, and they're all volunteering their time, architects, designers. It comes out once every 4 years and has enormous impact across North America and its influence in If you went to your state agency and said, can we build this or can we remodel this? They're going to look at the FGI guidelines to determine. So in 2022, for the first time, the FGI guidelines included EmPATH units in their manual. And so they have this specific distinction about what should be there in an EmPATH unit and how it should be designed and all the kind of, how many bathrooms do you need per each number of patients and all these kind of things. Because we're seeing that, can you just get me back to your first question, part of the question again? I'm sorry, I kind of went off on a tangent there for a moment.
Yeah, let me just scroll back down to it, but it was whether or not it's housed in an existing hospital.
Oh, how is it? Yeah, right. Thank you. That is the tangent. So according to the FGI guidelines, what they say is ideally an EmPATH unit is either within the footprint of the existing emergency department, the ER, or it's immediately adjacent to the ER. However, due to constraints and available land and construction, it can be anywhere else under the hospital license, either on that same campus or even on an additional campus. So I think the key about the EmPATH model is that it's affiliated with an ER, because it's going to be that place where anybody who comes in that ER who's got a mental health emergency that they move you to. If you came to the ER and you've got an acute case of blood sepsis, the ER is going to move you to their intensive care unit. If you come into the ER and you're about to have a baby, they're going to move you to labor and delivery. In the same way, if you come to the ER and you got a psychiatric emergency, they should move you to EmPATH. It's that kind of a simple, straightforward thing. It's best case scenario for everybody if it's as close as possible as the ER. That's not always possible. We'd much rather have an EmPATH than have a bunch of people stuck in a back hallway strapped to gurneys. So if that means we have to build it, a few feet away instead of right next to the hospital or right in the same campus, then at least we're doing much, much better than the status quo.
Okay, Marion, I don't know if we should take one more or with only the 3 minutes left.
Sure, let's take that last one.
Well, yeah, there's two more, but
Yeah, there are, but I think we've kind of answered Sean's question about, space in hospitals and rural situations and that sort of thing. Okay.
So the last question is there a minimum size bed capacity that you believe is effective?
Yeah, absolutely. The smallest one that I've seen that's operating is 6 chairs. I think if you're any smaller than that, it doesn't make a lot of sense because you're going to need too many staff for the number of patients you're intervening with, and that's going to be difficult to work from a staffing standpoint. It's going to be difficult to work from a financial standpoint. So if you're a hospital that maybe is only seeing 2 to 4 emergency behavioral health patients a day, there's other things that we know of that we can help you with. A program called, for example, Emergency Psychiatric Interventions, which is for regular medical ERs that see a smaller percentage of psychiatric patients, and how you can change the way the staff and the doctors work with them to have them have a really positive experience without necessarily having to have that separate EmPATH space. If you're seeing more than 3,000 emergency behavioral health patients per year, which sounds like a lot up front, but when you really think about it, that's only 250 patients a month, or roughly about 6 patients, 7 patients a day. That's probably more than enough to justify an EmPATH unit. We usually find that the minimum size for an EmPATH unit, which should probably be no less than 8 chairs, and then you're really getting several economies of scale. According to those FGI guidelines, there's certain things that are ratioed at 1 to 8, such as like you need to have a bathroom for every 8 patients. You need to have a shower for every 8 patients. You need to have XYZ for 8 patients. So anything less than 8 patients doesn't make any sense, because you're still going to have to pay for all the same things in construction and the same things in staffing as if you had 8 patients. So if you're going to be estimating less than that per day, talk to us. We can maybe use some of our academic suggestions and say, hey, maybe you might want to try to do this a little differently. Maybe you're a little too small, or maybe you want to collaborate with another hospital in your area to see if one of the two of you might want to have a shared empath. That might work. But like, as I said, I think I've seen a couple that have done okay with 6. They have interesting leadership and operational models that I don't think would work across the board for folks, but they work great for them. But 8, 12, 16, 20, 24, those there tend to be multiples of 4, and those seem to be the right size for empath units. Some of them are bigger than that, some of them much bigger. But I think when we're looking at the vast majority around the country, they're somewhere in that 8 to 20 range. And what's wonderful about that is that gives them enough capability and capacity to get people quickly out of that ER, which otherwise would make the psych patient's symptoms worse because of paranoia, claustrophobia, into that appropriate setting, getting them better from the first few minutes. And yet you don't have wasted space, and you're not kind of overdoing it. And when you really think of the empath unit as having a symbiotic relationship with your medical ER, that they're both helping each other, the empath unit is there to make sure that there's an appropriate place for all the behavioral emergency patients to get to as quickly as possible. Meanwhile, that medical ER is there knowing that, hey, if your doc determined, you know what, this person's situation is actually delirium, it's not psychiatric, we need to get back to the ER, that the ER takes them right back immediately. So when you have that nice to and fro, but really well-defined, guidelines, you have algorithms, flow charts, working relationship, it ends up being a great experience. But again, if we're talking about minimums, I think 6 is the absolute minimum, and 8 is probably the one that most places should shoot for. If you don't have enough patients for those, maybe we could find a different way for you to address your behavioral health population.
Thank you, Shane. I appreciate all the questions that people have forwarded, and this recording will be available on the NAMI Grand Rapids website probably within 4 to 7 days. It takes Mark a little while to process that, and so you'll be able to take a look at it again there. Appreciate everyone, almost everyone, hanging on till 12:30. And Dr. Zeller, incredible job. Thank you so much. Your background is so impressive in this area. Very grateful for your time here today. Good job with the questions, Shane. Much appreciated. Everybody is going back to work. And I'm hoping, Dr. Zeller, that we'll continue to be in touch, and hoping that we'll maybe local development. We'll see what happens.
It's been an honor chatting with everybody today. Thank you for inviting me, and I'm just very flattered to have been here. Thank you for the kind words. I do hope we stay in touch.
Thanks. You're welcome. Bye-bye.
Bye-bye.
Bye, everyone. Have a great afternoon.